Welcome to Season 2 of Public Health on Call, a podcast from the Johns Hopkins Bloomberg School of Public Health. I'm Joshua Sharfstein, Vice Dean for Public Health Practice and Community Engagement, and a former Secretary of Maryland's Health Department. Our goal is to bring scientific evidence and experience to the public health news of the day through informative interviews with scientists, community leaders, policy experts, public health officials, clinicians, and more. If you have ideas or questions for us to cover, please email us at publichealthquestion@jhu.edu. That's publichealthquestion@jhu.edu for future podcast episodes.
Today, as part of a periodic series on overdose and the pandemic, Susan Sherman, a Bloomberg professor of American Health and Health Behavior and Society, speaks with Chauncey Parker. Chauncey Parker serves as the director of the New York, New Jersey high-intensity drug trafficking area. They discuss public health and public safety partnerships around the overdose crisis, as well as the impact of COVID on the illicit drug market. Let's listen.
I'm excited today to be talking to Chauncey Parker, who's the director of the New York, New Jersey HIDA program. HIDA stands for High Intensity Drug Trafficking Area. It's a federally funded program that invests in public safety and public health partnerships designed to build safe and healthy communities around the drug supply. Mr. Parker also serves as the Deputy Commissioner for Community Partnerships at the New York Police Department. Chauncey is really an incredible person. He's been a veteran of more than 34 years working in criminal justice in New York, and he began his career in the Manhattan District Attorney's Office in 1986, where he served for 5 years. He next served as an assistant U.S. attorney for the Southern District of New York for 10 years. And then in 2002, Governor George Pataki appointed Mr. Parker to serve as the Director of Criminal Justice for New York State, where for 5 years he oversaw all state criminal agencies. In 2010, Mr. Parker returned to the Manhattan DA's office to serve as an executive assistant district attorney, where he worked until he began his current assignment at NYPD. So as you can see, he has a wealth of experience, as really has sat in many different positions in the field of criminal justice. Chauncey, thank you so much for joining us today.
Thank you for inviting me.
I'd love to start by asking you a bit about HIDA. It's such a monumental, unique collaboration. Can you talk about what it is?
Well, it really is a unique collaboration. I think HIDA is a grant. It's a federal grant that is overseen by the Office of National Drug Control Policy. And I think it began in the late 1980s. And the way it works is that the director of ONDCP, or the Office of National Drug Control Policy has the authority, together with Congress, to designate areas of the country as a high-intensity drug trafficking area. And they do it by counties, but the way it's structured nationally is by regions. And there are 33 regions, and our region is called the New York, New Jersey HIDA, or that's our region. And the way I look at it is we get funding from the federal government to invest in partnerships, as if we were a company. Like this is how do we invest in partnerships to build safe and healthy communities? And our area covers New York and New Jersey, and we invest in everything from law enforcement partnerships to investigate major drug trafficking organizations, fugitive task forces, money laundering. And then over the last several years, we've used the platform of HIDA to invest in public safety, public health partnerships to achieve a North Star of reducing drug overdoses.
Interesting. So can you give a few examples of some kind of poster child of those types of investments?
Sure. One of the is the partnership between ONDCP and the CDC, where they have partnered and pooled together their resources, their expertise, to achieve a common goal, which is to reduce drug overdoses. It started in a handful of states in the Northeast and is now a national partnership. But it's CDC and ONDCP pulling together. I mean, I think it's the platform for the national drug strategy, frankly. It's public health and public safety and community partners working side by side to achieve a common goal. Public health wasn't in the original mission statement for the HIDA program. And if you think about national drug control policy, you sort of have law enforcement having one lane that they rundown as it relates to drug policy. And a completely separate, and I would say disconnected lane is public health, and probably some other lanes as well. But certainly public health and public safety were not connected. Even though when you think about what's the purpose of drug policy, one of the key goals has got to be reducing the number of people who die from drugs. But we were doing it in two parallel tracks. And there's at some point where they really are separate parallel tracks, but some part of it is they really do overlap. So my point is that the HIDA program, until really, I would say the last 8 years or so, drug prevention, drug treatment, except for the Washington-Baltimore HIDA, which is one example, the one exception, because it was originally set up this way. It's been strictly a law enforcement program for the most part. And so it's only relatively recently that public health became a key part of the HIDA program. And I would say maybe that law enforcement became a part of CDC. I think that marriage and that partnership is relatively new, but it's expanded very, very quickly because I think both public health and public safety see a real benefit of it. I would tell you one other thing from a New York perspective. What we started, I think in some sense parallel to this, or maybe it was maybe an inspiration for this, but we started with the New York City Police Department and City Health an initiative called RxStat. This is when Mayor Bloomberg was the mayor of New York City. It started then, and it has grown, but it is a partnership of city agencies who are committed to reducing drug overdoses in New York City. It's called RxStat, similar to the NYPD has CompStat, which is to reduce crime, which is sort of a national story of success. Similarly, we try to apply that same principle to reducing drug overdoses, and it's called RxStat. Has 20 plus agencies from public safety, public health, everybody in between, looking at the same map at the same time, sharing ideas, filling gaps, trying to save lives.
When did RxStat start?
It started in around 2010.
And was that around the same time that the CDC and HIDA started collaborating together, or ONDCP and the CDC? Or that was a little bit later?
It started a little bit later. It started, and it was driven in particular by, at the time, the opiate pill epidemic, which became then the heroin epidemic, which then became the fentanyl epidemic, then became the national epidemic with stimulants and everything else. But it was, in particular, it was the rise, OxyContin, everything that was driving drug overdoses to new heights in New York City.
Right.
Mayor Bloomberg put together a team to really apply data-driven strategies to reduce drug overdoses.
So how was that? And we're going to get back to the CDC collaborative because I think that's so interesting. But RxStat is so unique and really was a collaboration between public health and public safety from the beginning. What was it like? You described your meetings were literally sitting around with different entities, looking at maps and talking about data for various jurisdictions. Like, how did that work?
Well, we had started in the police department at the time, Chief Dermot Shea, who's now the police commissioner, but the police department in particular, much like I'm sure people at Johns Hopkins, very driven by data and wanting timely data to be able to know, once we know what you set your goal, but you need to know data to know how we're doing against it with that data. And I think that with drug overdose data, when we first started, it was challenging because it takes time to get confirmed drug overdose data. So one of the innovations from this, and Commissioner Shea and others played a really key role in this. One of our meetings, the medical examiner said, "Well, I don't know this is helpful, but when somebody who's passed away comes to the morgue, we know that day, I would bet with 90% accuracy that it's a drug overdose, based on the circumstances of the death, the paraphernalia at the scene, talking to family members and friends. I think we kind of know that day with about 90% accuracy. So with that model in mind, the police department, working with public health and with the OCME, created a daily presumed overdose report. So that instead of getting the information maybe 6 months or a year later, was confirmed. And as we then measured it against the confirmed overdoses later, it turns out that daily confirmed overdose report is 90% accurate. So all of a sudden we had timely, accurate data that we could use to develop more rapid responses to some of the challenges. The other kind of thing I think I would just say, Susan, that came up, but just by putting us around the table together, is that there would be a fatal overdose. Somebody in police department would describe a fatal overdose, and there were drugs, and there was a straw maybe at the scene. And the question was, did the police ever seize, would they seize that and voucher it? And we went from it not being seized because it was a drug overdose. It's really a good question. This is for the medical examiner. But the public health people said it would really be helpful if you could get what's in that straw could be very important. This was at a time, particularly when fentanyl started to be mixed in the drug supply. The powder drug that was found was cocaine, and what's in the straw becomes very important because are they mixing fentanyl and they mixing cocaine together, and you would know through that injection just like you know through a syringe. So not only did the police start to recover that systematically, they tested it, and they then started to share that data with the health partners. And so just little by little, it was really literally 100 examples of just by people working around the table together, things that I had no idea could be helpful to public health was helpful to public health.
It's so interesting because partnerships like that, it is so painstaking for so many jurisdictions, for example, to get the overdose data. I mean, if it's lagged by 2 weeks, in some places it's lagged by a quarter, 2.5 months. And to get over the bureaucratic hurdles of data speaking to each other, departments speaking to each other is really no small thing. So that's really amazing. And I think what you're saying is once you start to get the small wins and see the value, you quickly you have more buy-in in real time of what can we share next because it's so useful to so many people. So let's talk about COVID a little bit. Obviously, we're talking right now as rates are skyrocketing. It is mid-November 2020, and the rates just every day, we are in kind of a free-for-all, it seems. New York City may be back in a bad place. Your numbers were looking good for so long after some really intensive public health programming was implemented. How do you see the impact of COVID on the work that you do and on the drug supply in New York?
Well, if just from a drug trafficking perspective, and I always think of drug trafficking, it's a business like any other business. I know that's an obvious point, but I don't think about it enough like that, because if you think like a business person, then you can almost anticipate the modes. But so what there was an impact in terms of when the city was really shut down April and May, when we were at the worst, the highest rates of COVID deaths. I think almost 20 is now, I think 24,000, but it was about 20,000 people in a very short period of time. And the city was shut down. I think everything to some extent was frozen in place. I think I would just say this as a general statement. There may have been a momentary disruption of the drug market and the drug flow, but the drug flow is still consistent where our law enforcement agencies are seizing drugs at the same rate or higher than ever before. It's just New York City is still the marketplace with not just heroin, fentanyl, methamphetamine, cocaine, drugs being packaged made into pills, drugs being put into glassine envelopes. So there's unfortunately a vibrant drug marketplace in New York City. In terms of the deaths, I don't have that data because that data, the official data, we need to get that through the medical examiners and city health, and we don't have that available yet.
So that's interesting. I mean, because so much of fentanyl and the precursors come from China, I wonder how, do you know where your fentanyl is sourced that comes into New York City from any kind of footprint from?
I think the experts obviously will be DEA, but my sense of it is that less of it is coming through China, which would be in smaller amounts. It's much more over the southwest border through the Mexican cartels. That's much more of a source of fentanyl. And it's also, again, if we think of it as a marketplace, fentanyl was in some a little bit of an experiment. Probably that's the wrong word, but it was started to appear in the drug supply and then flooded the drug supply. And it's straight economics. That a tiny bit of fentanyl is worth a lot more of expensive heroin, and you can make a lot more money. And then they mix it with stimulants, not just with heroin, but also with stimulants. So it's in I would say it's too general, but in everything.
It was an amazing reaction to interdiction, right? That there was a lot more confiscation of heroin. And so you're right, the market kind of corrected itself by having and can make more money, something more powerful, smaller quantity, more likelihood of getting in.
Yeah, and I don't know, Susan, I don't know if it was a reaction to interdiction or it was just the way the market works. The cartels are much more established and have an infrastructure to do national, distribution of drugs. So similar to methamphetamine, there were sort of mom and pops, that's the wrong word, but let's say, for lack of a better word, there were homemade methamphetamine places, right? And then the Mexican cartel said, look, there's a market out there. It's almost like, a big company taking over the smaller companies. They said, well, we're going to have super labs and we're going to produce methamphetamine on a massive scale, similar to fentanyl. So I think it's more the cartels see a business opportunity where a market started to develop. They then activated their infrastructure to react to supply that.
Interesting. How is the work continuing in this COVID context? Has HIDA's work changed? Have collaborations changed? Obviously, we're all living in Zoom meetings, but how's COVID impact the actual work?
I think that from a law enforcement perspective, law enforcement spends its time not in the office. And so that's continued. They're out and they're doing their investigations and continue to do very significant investigations. I know not just New York City, but across the country. So I think from an enforcement perspective, they're not missing a beat, it seems like. I think operationally, of course, we're on Zooms, and that's the way for civilians, so to speak. That's been the way that we've been moving forward. That's been the biggest difference.
So it hasn't really stopped the work or seizing of the drugs or evaluation of the drugs and things of that nature.
Definitely not operationally. I think what you see in the drug side, you see just like people price gouge with N95 masks or other key supplies. I think you can see it in some areas, somewhat in New York City, but I've read about it in other parts of the country where the price of heroin or cocaine went up because of COVID. But we'd have to talk to the drug dealers to know whether that's real or are they taking advantage, because the price of an N95 mask didn't actually go up, but
right.
People seem to think that there was an opportunity, which is not good, to charge more for one.
Right. My last question is, are there any things that you'd like to see in terms of new public health and public safety collaborations in thinking about how we reduce the burden of the overdose epidemic? Some people have said, and it really scares me, that when it's all said and done and we're used to we've become desensitized to death with COVID. I mean, the numbers are just so crazy. We might, on the other side of it, just think that, 72,000, 75,000 people who die a year from overdose, it's just now one of the leading causes of death, and we move on, which would be really, really scary because it's unacceptable. So, A, I'm curious what you think about that, and B, can you think about, as we come out of this pandemic, hopefully, what are other kinds of public health and public safety collaborations that can work to reduce the burden of overdose deaths?
Well, I think it can never be normalized, the number of people who, whether it's COVID or drug overdoses or people who suffer in any way, that it never can be okay. We can never normalize it. We have to keep pushing, and we have to stay forever optimistic that we can make things better. Otherwise, let somebody else be a public servant. That's our job. I think when I think of what we can do going forward, I'm very excited, because I think the future is collaboration. And I think it's in everything that we do in government. We have to pull everybody who's a public servant from their different worlds to the table to look at this with a common goal and do everything they can to make a difference. I think with public health and public safety, I just mentioned a couple areas where I think that we really can work together. I think the intersection of public health and public safety we work with people who are mentally ill. That we're finding in criminal justice, whether it's in people who don't end up in jail, people who do end up in jail, or people who intersect. There's a lot of people who suffer from mental illness who are not getting the care that they need, and it's not going well from a criminal justice perspective or a public health perspective on these two independent tracks. It's not doing too well because they keep coming. We keep seeing them over and over again, at the homeless level, all the way to the level of people who go and commit very, very serious crimes, end up in state prison. But we need to do better. And so many of those people suffer from also a substance use disorder, which would be not hard to imagine, because that they can self-medicate, or that may be what drives it. So I think that's an area of coming together, public safety and public health coming together, particularly as we come up with making progress and success with people who suffer from mental illness, dually diagnosed, I would say. A second area, I think, is with prevention. I kind of feel like we haven't scratched the surface we should be as creative as, the people who sell iPhones and everything else that get people to want to buy and have a craving for. Hire the people, get people to have a craving to click and click and click on the, in this thing or that thing on Amazon. Have people have that same craving not to use drugs. Right. And figure out a way to help them. If people then do and they suffer, then let's make sure we have the best treatment interventions. But on the front line, let's make sure we're doing everything we possibly. So I think that HIDA and public health can create a platform for evidence-based strategies to prevent drug use. And then the third, I would say, just as an example, I touched on it earlier, is I do think one of our failings or an area that we could really do so much better is people, if they do intersect with criminal justice, if they do go to jail, if they do go to prison, our recidivism rate for a country that leads the world in incarceration should be much more important, and that we should be doing everything we can, like a company or whatever, that sets a North Star to reduce the number of people who you leave prison. We should dramatically figure out those interventions, those strategies, those opportunities that dramatically reduce the number of people who come back. It's in all of our interests, and it's also the right thing to do. So, I think I think this public health, public safety platform is the foundation for a national strategy. If I was an investor, I would invest one where I would know that the money is going to be used and it will be measurable. There'll be a measurable difference. That's the place I would invest.
That is a great place to end. Thank you so much for your time today. We have been talking to Chauncey Parker, and we really appreciate all that you've done, and thanks for joining us.
Thank you so much for inviting me, Susan. And I look forward to working together.
Public Health on Call is produced by Joshua Sharfstein, Lindsay Smith-Rogers, Stephanie Desmond, and Lamari Morales. Audio production by Spencer Greer, Niall Owen McCusker, Cian Oates, and Matthew Martin, with support from Chip Hickey. Distribution by Nick Moran. Thank you for listening.